Hi, folks. Welcome back to OTD 506 Pharmacology. We're getting started today in Chapter 8, which is about cardioactive drugs, specifically targeting congestive heart failure, which is a combination of cardiac and pulmonary manifestations. Usually it's the heart driving inflammation in the lungs. And we're also going to get after a little bit of arrhythmia as well. We're going to get into some causality here. I don't want to get too far down the rabbit hole, but it is important to understand a little bit about what drives these two things, CHF and or arrhythmia. That's going to cause a prescribing physician, cardiologist, to give these drugs that you then have to deal with in your patients and clients. So we're going to be, this was originally just shy of an hour-long lecture. I've broken it up into two pieces. The first one's, this one right now is about 25 minutes or so, and the next one's just slightly longer, closer to 30 minutes. So good luck, and let me know if you have any questions.
I think this is one of the interesting chapters in our course this semester. It's dealing with congestive heart failure and arrhythmia, and it's actually a really astonishing, a truly astonishing statistic that there's a 1 in 5 lifetime risk that of developing heart failure in the American population. 20 million worldwide, but that's growing as the Western diet has spread. And so, what's the difference? The definition of heart failure is when the heart is not pumping enough blood to satisfy metabolic need. Turns out too now that especially since World War II, when it became permissible for women to smoke, it became more permissible for women to be socially active in terms of drinking and so forth. That women have ostensibly caught up with men. They still have a lower risk in younger age groups, but by the time you get to your 70s or 80s, women have more than caught up with men. And the unfortunate side of it is that women will often suffer from catastrophic events more often than men because elevated levels of estrogen actually promote collateral artery formation, and so women tend to be asymptomatic until you have a truly catastrophic event. So all of these habits here are really worth looking at, in small ways, not in huge, grand gesture ways, but in small ways. So take a look. This is really good stuff. Let's get to the definition of congestive heart failure, which fundamentally involves a crisis in the heart where there's an imbalance between the left side of the heart's output and the right side of the heart's output. Most often, what you have is that the left side is no longer capable of squeezing and removing blood from its chamber at the same rate that the right side is submitting blood to the pulmonary circuit. So there's more fluid coming out of the right side than there is coming out of the left side. And what's in between the right side and the left side is the lungs. And with that imbalance, the fluids building up, the pressure rises inside the lungs, and fluid deposits in the alveolar spaces. They can be inside the alveolus or even in between the alveolus and the capillaries. But that's what congestive heart failure is a fundamental imbalance of cardiac output between the sides of the heart. Given what I just said in the previous slide about left side versus right side imbalance, it's not the only kind of heart failure out there. So we do have this left-sided failure, and we also happen to have right-sided failure, also known as cor pulmonale. Now, in this case, what's going on is that the right side can no longer deliver to the pulmonary circuit, and what you see is a backup of fluid in the venous side uh, of the equation. So that's a slightly different variant. But left side is much more common because there's so much more pressure. It's a higher pressure system than the right side is. Both of these things are possible. What drives heart failure and then the congestion therein can be problems with the heart muscle itself, cardiomyopathy, so something inherently wrong due to genetic defect or something else, infections. It can be due to ischemic disorder, insufficient blood supply and or overt crisis, myocardial infarction. It can be due to hypertension. That is to say and we call this afterload. This is the heart trying to deliver fluid into a higher pressure situation, which means it has to work harder to squeeze that blood out of its ventricles. It can be due to issues with valves, either a slight loss of patency in the valves or an overt failure of valves. When you have a failure like that, what's happening is now you're pushing blood back the other way, and that can lead to lots of problems and buildup of pressure. Congenital malformations where like atresias or something along those lines where the heart is trying to push blood into either a blind end or a constricted vessel of some kind, increased pressure, increased workload, that's no longer productive. Coronary artery disease, and this kind of gets us back to ischemia and or myocardial infarction. What you've got going on here is reduced MVO or increased MVO2, decreased perfusion. So now the heart's trying to overcome that by working even harder. And we can stage these things out. So you have stage 1, which is relatively mild, doesn't affect occupation particularly. What you begin to see is increasing intolerance to regular daily exercise. And 3, what we would see is excessive fatigue. So they're very, very tired. The point where they can't complete normal tasks. And then finally, stage 4 is where any activity other than just complete rest causes physical discomfort. And some of the symptoms that we're seeing, depending on whether it's left side or it's right side. What you're seeing on left side is that you're seeing this elevated heart rate. They can't breathe enough. You might see signs of loss of oxygen, and then you see decreased mental performance and certainly buildup of fluid between the left and the right side, etc. On the right, you see fatigue. You'll see jugular vein distension because the fluid is just building up in the large vessels. Edema, because again the blood is the pressure on the venous side is increasing, and so forth. This is the figure from your book showing you what we call the vicious cycle of congestive heart failure. The fundamental part of this is that the heart is failing, and when the heart begins to fail in terms of it can no longer sustain an output, whether it's left side or right side, left side again more common, you see the body trying to goad it. And I don't want to say it like they have some kind of malice or something, but what we're seeing is the cells will send out signals that say, hey, we need more oxygen, we need more glucose, and that's sympathetic. So if cardiac output is reduced, we will see this attempt to get it going, and that causes constriction of vessels and retention of fluid in the kidneys. So we see the vessels getting constricted because that's the sympathetic side of the equation in order to raise pressure. What you're trying to do is convey pressure from the heart to the capillaries, and that means increasing resistance, increasing pressure. That's going to put more load on the heart, and that's why we see this elevated afterload, because what we see is that when you reduce the heart output, blood pressure falls, and then we get this sympathetic tone. So we're going to directly stimulate the heart, we're going to vasoconstrict the vessels, and that leads to all kinds of problems. Again, the same signals will then lead the kidney to want to retain fluid, so that's aldosterone. And then we also see angiotensin in the combination of the kidneys and the lungs. And angiotensin is a very, very powerful vasoconstrictor, as well as retaining fluid. And again, that all leads to more load on the heart and a progression of failure. It is a vicious cycle. So what you'll see is that it'll kick in, and you might start here over a period of time, but then you'll sort of rapidly progress to a true medical emergency. Here are some pictures showing you a normal heart versus issues of either a weakened heart muscle that can't squeeze as well, or the opposite where you have what's called diastolic heart failure. Diastolic heart failure is where you have a buildup of the muscle to the point where you cannot open up the chamber of the heart as large as it was. So you have more muscle there, which means it can squeeze more, but you have a smaller volume. And so it's kind of a vicious, again, back to this vicious cycle. Either you can't get rid of the blood that's in the chambers there, or you don't have enough volume because due to the stiffness, lack of compliance of the heart. And so what's the goal in congestive heart failure therapeutically? Is to increase contractility, that is to be able to get the heart be more able to contract, more able to move blood, and secondly to reduce load. Try to reduce the amount of work the heart has to do in order to move blood properly. Now we have lots of agents available that can affect different aspects of cardiac function. And all of these are examples of how we can categorize drugs according to what they do in the heart, whether it's something that's affecting ion flow or conduction speed or rate of contraction or vasoconstrictors, vasodilators. So these generic terms, pressors, inotropes, chronotropic agents, lusotropic, which involves relaxation, dromotropic, which affects heart rate sort of like chronotropics are, but it's more specific for the AV node, and then excitability, what we call bathymotropic agents. The two styles of drug that we're going to probably work with most likely in congestive heart failure would be try to increase contractility and modulate heart rate, so inotropic and chronotropic agents. And so here are the four major groups of agents in terms of what they are or what they do. The first category are known as cardiac glycosides because they are a carbohydrate with a little bit of a lipid sort of thing going on. These things are going to affect contractility. We have phosphodiesterase inhibitors. Okay, so phosphodiesterase inhibitors like right here, this phosphodiesterase, this again will increase the contractility by preventing the diminishment of cyclic AMP. Cyclic AMP increases strength of contraction, and so by keeping cyclic AMP around, by inhibiting what would break it down, leads to increased contractility. Diuretics, what we're trying to do here is reduce load. Okay. ACE inhibitors are the same way. We're trying to reduce load. So 1 and 2 are contractility agents, glycosides and PDE inhibitors, and then diuretics and ACE inhibitors are affecting overall load on the heart. The risk of congestive heart failure and overall diminishment of cardiac output is fundamentally a chronic situation. It's very rare that you would have just a sudden episode of this. So it is something that a patient will most certainly be dealing with for the duration of their lives if they are diagnosed with it, or they're diagnosed with a significant risk factor like hypertension. So people that have coronary artery disease, hypertension, maybe have diabetes, and certainly are obese, the key here is to try to prevent going into a congestive heart failure crisis. The statistics are pretty grim. If someone presents in the emergency room with congestive heart failure, the usual time to death following that first event is 5 years. So they tend to be fairly aggressive about dealing with this, or on a preventive side if possible. So what we're going to try to do is control their hypertension to reduce the load. That's the most direct way of improving outcome or improving overall lifestyle changes. Get them to lose weight, try to get their blood sugar under control. And that's why we see in this early stage, if they are at risk of progressing, primarily diuretics or antihypertensives, ACE inhibitors, angiotensin receptor blockers. If they progress and they have some other signs, like for instance left ventricular remodeling, or they see signs of issues with valves, and so the ejection fraction is screwed up, or they have a history of a heart attack, they're going to do the same as A, but they're going to start trying to augment the antihypertensives with beta blockers to lower cardiac workload, or a defibrillator should the heart go into an arrhythmia. And then from there, again, we're stacking on each time. So we're adding more and more. So we have those diuretics, ACE inhibitors, beta blockers, and then we're adding some other things. Now there's where the cardiac glycosides come in. When they start to see fatigue, so we're starting to enter those stage 1, stage 2 congestive heart failure symptoms. That's where we see digitalis and so forth, and then from there. So it's a progressive thing. We're talking about a chronic disorder, one that you manage over time as opposed to cure. So the primary agents for congestive heart failure, we're going to start with group 1 here, the cardiac glycosides. These are sort of a combination of carbohydrate and lipid. Really cool, interesting compounds. Digitalis, also known as digoxin, ubain. These are derived from plant molecules like the foxglove. That's where the name digitalis comes from. And what we have is a straight up inhibitor of sodium potassium ATPase in the heart. And this is a really kind of an interesting contradiction. So what you have going on is that if you inhibit the sodium potassium ATPase, that leads to increased elevations of sodium inside the cell, and the sodium actually can work as an exchanger with calcium. So that with this increased sodium, that leads to increased exchange for calcium, and then that calcium then increases contractility. So it's a really interesting drug from that mechanistic standpoint. I would love to study more about how this drug was determined to be a beneficial agent. Because in my mind, if you'd inhibited sodium potassium ATPase, you would be doing a great disservice. But in here, because there's more calcium, calcium is king in terms of strength of cardiac contraction.
The primary agents for congestive heart failure are the ones that will slow the heart down, but at the same time preserve strength of contraction. And the frontline drugs for this are known as the cardiac glycosides. They are actually glycosides. They're actually kind of a form of carbohydrate. These are carbohydrate rings on here bonded together. That's why it's called a glycoside. It's got a little bit of a lipid in here, gives it a little bit of permeability. But they're derived originally from the digitalis flower plant. Okay, this compound is a cardiotoxin in its fundamental sense, but what it's doing is it's affecting the heart in a way that it preserves intracellular calcium. If you study heart function, calcium is king. So calcium inside the heart sustains a stronger contraction. So better calcium kinetics means a stronger contraction. But it has these side effects of slowing the heart down. So it's a mix of increasing the strength of the contraction, but slowing it down. Problems though, low therapeutic index. So these are cardiotoxins. Okay, they are not to be treated lightly. They can very quickly cause severe bradycardia and have to be monitored. You also have to monitor withdrawal situations if for some reason you don't want to do sudden withdrawal with these drugs. So because they are driving, the primary mechanism is that they're driving intracellular calcium. They're actually inhibiting the sodium potassium ATPase, and that loss of sodium gradient means you can't export the calcium. Now, it also is known that these drugs will digitalis and especially ubain will affect hypokalemia because they also will affect transporters in the kidney. So you can get loss of potassium, which is another issue with the low therapeutic index. That's because these things act as diuretics. Turns out digoxin's a little bit better than the other two, and it's probably the front line of the three at this point. It can also cause GI disturbances because of its non-specific effects in the gastrointestinal tract that the book describes just a little bit. Does have CNS effects. It's hard to say exactly why. It probably has something to do with a combination of the calcium, because you use calcium to release neurotransmitters in the CNS. And it may also be because of the inhibition of sodium potassium ATPase, but not super important. Just know that this is one of the major risks of side effects. In addition to the cardiac glycosides, we also have this category of drugs known as phosphodiesterase, and this is the type 3 phosphodiesterase inhibitors. These ones specifically inhibit what is known as PDE3, phosphodiesterase 3. That's shown in the figure below. I'm going to underline it right here. So there's phosphodiesterase 3 for you. Phosphodiesterase 3 is like the off switch for this signaling pathway. So when we have sympathetic activation, and generally somebody who's in congestive heart failure is suffering from hypersympathetic activity to begin with. They're stressed out, they have high metabolic need, their heart is failing, so they're probably pumping norepinephrine like crazy. So here's norepinephrine from a sympathetic neuron, and norepinephrine is going to stimulate, in particular, beta-1 adrenergic receptors. When these receptors are activated, they turn on an enzyme that creates a second message called cyclic AMP. So we metabolize ATP into this second message. Well, we have to be able to turn that message off. And phosphodiesterase 3 is the protein or the enzyme that will turn cyclic AMP into non-cyclic AMP. There's no little C in front of this. This is adenosine monophosphate. Cyclic AMP is cyclic adenosine monophosphate. So this is the off switch for this signaling pathway. Now there are a number of reasons why they think that this works in CHF. It probably lowering down sympathetic activity, letting parasympathetic have a little more sway on the heart. Parasympathetic does tend to dominate the cardiac function, but if you have sympathetic, it'll muck up the system. And so this is basically trying to dial down that sympathetic signaling. Now the problems is that you can really only use this for short-term use. Okay, so it's really only good for short-term use. We can shut this down for a period of time, but it will lead to problems. So we're going to slow contraction down, slow strength of contraction, but it's only good for short-term use.
So both of these, the cardiac glycosides and the phosphodiesterase inhibitors, are sort of late stage agents when you're in more crisis situations. The other drugs, diuretics, again, I mentioned beta blockers in the previous slide, and ACE inhibitors are all designed to reduce the load on the heart. So the diuretics are designed to reduce blood pressure by reducing the volume of the blood, try to lower overall afterload. Beta blockers are trying to slow the heart down, reduce its load that way to try to allow it to recover a little bit. And then ACE inhibitors are the same story. What you're doing again is trying to relieve load on the heart by facilitating excretion of fluid. So I'm not going to talk about any of these right now because we have separate chapters for all of them. They're very, very important drugs for more than just congestive heart failure. So we will have chapters on each of these three things. And here's a table from Chapter 8 showing you some examples of what we're talking about. So here are the diuretics down here. These include loop diuretics, which affect the loop of Henle. Most importantly, Lasix, also known as furosemide. You also have thiazide diuretics, which are working on the distal tubule. In both cases, the issues here are that you might get low blood pressure, which means orthostatic hypotension. What happens is you get up and you're dizzy, or you're just dizzy just because of low blood pressure. These are also known for causing low blood potassium, which itself can be an issue with nerves and the heart. And there are other side effects as well. But again, these are very, very common drugs, and so we're going to see lots of possible side effects here. Then we have the beta blockers, and you can always spot a beta blockers because those OLs like ILOL or OLOL. Those again are going after those beta adrenergics receptors, and again dizziness and hypotension, slow heartbeat. Those are all examples of things that you do when you are messing with the adrenergic receptors. And then finally here, the ACE inhibitors. Again, these are the prils. And again, we have hypotension, dizziness, issues with potassium. You do get this cough too. You get this idiosyncratic cough with ACE inhibitors. Again, we're going to talk about each of these drugs in other chapters.
All right, so we're going to pause right there. We will pick up in the next segment on this chapter, starting with anti-arrhythmia drugs. Talk to you soon. Thanks.